I am honored to introduce our next speaker, Alexander Pronko. Alex graduated from Wake Forest University with a bachelor's in science. He's a second year here at Robert Wood Johnson. I'm lucky to have Alex both as a fellow classmate and as a dear friend. While Alex will always be the one to come up with a pun or a joke for seemingly any situation, he's also one of the most insightful, thoughtful, and caring individuals I know. In hearing Alex's speech, the committee has been touched by the story that he has chosen to share, and even more so by the way his experiences have moved him to find ways of making us better physicians. So without further ado, please welcome Alex Pronko.
Early this fall, just after our neurology exam, I received one of those frantic, life-changing phone calls that one hopes they will never get. My grandmother was in the ICU, unresponsive. I grabbed my sweatshirt. I rushed to the car. I flew down the highway. I walked straight to her room. I crossed the threshold and I froze, stunned at the scene that lay in front of me. There, tiny, amidst the huge hospital bed, lay my grandmother. Her face was chalk white, contrasted only by the bruising from her fall. Her lips were cracked and dry underneath the ventilator tube. Her eyes were almost leathery, open, but not seeing. Each breath she took racked her small frame with a sickening shudder. She was so frail. How did she get that frail? My vision narrowed and I couldn't tear my eyes from the bed. The constant beep of the heart rate monitor and the whoosh of the ventilator felt almost deafening in the silence. Everything suddenly felt awkward and wrong. I didn't know what to say, where to stand, what to do with my hands. My heart was racing and I wanted nothing more than to walk out that door and pretend none of this was actually happening. Instead, I just stood there and stared. Finally, my mom's voice seemed small as she broke the silence. They say she's not doing well, and her creatinine something is 12. What does that mean? Instantly, I was torn from the room. 12? 12, she said? 12? Too high, that's too high. Can it even get that high? Then my train of thought derailed and my mind exploded into a jumble of acronyms and words. CCR, GFR, BUN, AT2, JG cells, shock, shock, shock. I kept quiet and I gave my mother a hug. I knew that a creatinine level of 12 indicated acute renal failure. But no one was going to give me a pat on the back for diagnosing my grandmother with shock. Go say hi, my mom said. My legs felt awkward and heavy as I walked up to the bed. I reached my hand down to touch my grandmother's arm and instantly pulled it back. She was so cold. I returned my hand. Hi, Grandma, I said. It's me, Alex. I'm here. I felt so out of place. Why? It wasn't the hospital. I'd been in dozens of rooms like this before. It wasn't the people. I was surrounded by my mom and my dad and the grandmother whom I love so much. Why was I so uncomfortable? For the rest of the week, I found myself split between two worlds. On one hand, my medical education allowed me to translate for my parents. I could talk about test results. I could discuss treatments. I could even guess at what the doctors might do next. On the other hand, I was a family member with a very sick grandmother. There were times where, mid-explanation, I would find my voice cracking, my eyes welling up with tears, as I realized the impact of what I was saying. I felt so guilty at those times. Here I was, calmly rattling off all the causes of pulmonary edema, while my grandmother lay there, fighting for each breath. And the entire time, I couldn't quiet this one tiny voice in the back of my head, one that weighed heavily on my soul. She's not going to make it out of the hospital. It pervaded every thought. It underlined every conversation, but I couldn't bring myself to talk about it. I tried, but I couldn't find the words to say. My lips sealed shut, my tongue got heavy. I didn't talk about advanced directives. I didn't mention hospice care. I didn't ask the question, what if things go wrong? You see, my medical education allowed me to put each piece of the medical puzzle together. But here, the puzzle wasn't important. When it came to the truly important questions from my family, I was out of answers. Is she in pain? Will she get better? When should we withdraw care? As it turns out, I'm not the only medical student who struggles with these conversations. We're finding that medical students around the world don't know how to talk about death and dying. Increasingly, we're becoming aware that the problem, at least part of the problem, lies in how medical students are trained. You see, medical school teaches us how to talk to patients. It teaches us to solve the pieces of a medical puzzle while reassuring the patient, while providing empathy. It teaches us to show that we understand where the patient is coming from, that we will do everything in our power to solve their medical problems promptly and professionally. It teaches us to provide hope. But what do we do when hope is no longer on the table? What do we tell the terminal patient who's afraid to die? What do we tell the husband who can't bear to see their loved one suffer? What do we tell the family that can't bear to live without their family member? When it came to these questions, I found my education lacking. I didn't know where to begin. Studies of third and fourth year medical students around the world show that students feel that end-of-life care is extraordinarily important towards their future careers. However, they also show medical students do not feel comfortable talking about death and dying. Altogether, this isn't surprising. It's unrealistic to expect students to navigate the poise, the tact, the professionalism, the ethics, the emotions that go into having a conversation about death and dying, especially with complete strangers. I couldn't even have these discussions with my own family. So just how big is this problem? Is it local? Is it national? Is it global? How far behind are we on end-of-life care? Disturbingly, almost none of the recent literature on students' attitudes towards death and dying come from the United States. The studies we do have are woefully out of date. Yet they show that of 1,500 medical students in their third and fourth year surveyed, 60% feel uncomfortable talking about death and dying. 50% feel uncomfortable with their own thoughts about death. More recent literature from Europe shows the same story. After 4 days of ICU care, my grandmother came out of her coma. As a family member, it felt miraculous. My heart soared, my hope returned. My grandmother was back. She could see, she could hear, she could talk, she could remember all the details leading up to her hospitalization. She even asked me how my neurology exam went. I found myself smiling along with my mom and my dad. The air in the room had completely changed. Then, my training kicked back in. What's her kidney function? Are all her cranial nerves intact? I pulled my mom aside and I urged caution. She knew that it was not time to celebrate yet. But things were looking up. My grandmother's kidney function was getting better. She was taking off all pressors. Each problem seemed to be resolving. Every problem but one. One nerve. My grandmother couldn't swallow. One nerve. It hung over our family like a dark cloud for the next couple of days. Our talks went from when she can swallow to if she can swallow, and finally to the dreaded G-tube. We were so close to having my grandmother back. She was laughing at jokes. She was talking about Derek Jeter's last game. She was heckling the nurses. One nerve. I felt so frustrated, so powerless. I could see that nerve in my head. I could trace it. From where it started in the brain to where it ended. I could tell you every structure it innervated along the way. But I couldn't change the fact that my grandmother was unable to eat. My months of training in neurology, my hours of studying, only served to make me feel more frustrated. I knew there was no medical cure for my grandmother's problem. All we had was time and hope. I brought back my own story to make a point. End-of-life care isn't easily captured in lectures or textbooks. The line between critical care, end-of-life care, and recovery can be tenuous, mercurial, hard to understand. Frustration and uncertainty is felt just as strongly by healthcare providers as these emotions are felt by family members and patients. I mentioned the need for medical students to be able to have a conversation about death and dying, about end-of-life care. But I should have said conversations, plural, because there will be many. Each day in end-of-life care can bring a frightening new emotional roller coaster. And these emotions can quickly become overwhelming for students. Studies show that students with no prior experience in end-of-life care, when put into practice situations, display psychological defense mechanisms like blocking or downplaying a patient's emotions. When faced with a patient's emotional distress, a student might say something like, "It's okay. No one wants to die." It's okay. No one wants to die. How hollow and callous does that sound? Can you imagine for a moment if someone said that to your loved ones? Yet the blame for this seeming emotional neglect does not lie with the student. When faced with overwhelming emotions, the student resorts directly to their training. It's okay. No one wants to die. When broken down, is a statement that reassures the patient. It's a statement that shows the student understands where the patient is coming from. It's a statement of empathy. This may work well in regular care, but in the context of end-of-life care, this kind of empathy, this kind of hope, is hurtful rather than helpful. We need to empower our students to hold the tact, the empathy, the ethics, the knowledge needed to talk about death and dying with their patients. We need to train them to meet the daily, variable needs of the patients and families at the end of life. We need to find the right kind of hope. The good news is that around the world, countries are starting to recognize the problem. Standardized curriculum requirements for end-of-life care are being implemented. Programs that use role-playing or guided clinical experiences show wild changes in students' attitudes, drastic improvements. Just a couple days with standardized patients makes more confident doctors, more confident students. And this confidence follows the students to graduation. Changing the curriculum works. Unfortunately, the United States once again falls behind at this mark. Currently, our curriculum requirements set by the Liaison Committee for Medical Education simply asks medical schools to cover the important aspects of end-of-life care. This has led to wildly varying experiences for students, with the most common method of education being large-scale lectures. These lectures may work well for legal issues, medical ethics, but they do not facilitate communication. Less than 40% of students in the US role play in end-of-life care. Less than 30% interact with a terminal patient at all. Optional programs show low attendance rates and arguably miss the most crucial student audience. Simply put, end-of-life training in the United States right now is inadequate. So what can be done? We need to get our students more comfortable with end-of-life care. Emotional intelligence and communication skills are what students worry about the most. We need to have our mentors have a conversation about end-of-life care. We need to brainstorm challenges that might arise. Just as I said, a day of practice with standardized patients changes attitudes, brings confidence, and with that confidence comes knowing what to say and when to say it. More simply, let's add a what to tell the patient section to our history and physicals. Let's get our students thinking about these matters in a way that faculty can review and reflect and influence what our students address. In my own story, my grandmother wound up making the hardest decisions for us. Her kidney function declined, and she refused a G-tube. She passed away comfortably, quietly, surrounded by the people she loved. In the end, that's what was important to our family. That our grandmother was comfortable, that she knew she was with the people that loved her so much. Sometimes in medicine, that's what hope means. Hope for comfort, hope for quiet, hope for peace. The next time a patient is scared, the next time a student is overwhelmed by their emotions, let's have their training find the right kind of hope. Let's train better, more confident, more capable doctors. Thank you.